Chengai Medical College, Chettinad Hospital and Research Institute, Melvarattur Adi Parashakti Institute of Medical Sciences and Research, Sri Balaji Medical College in Harvard. The Satyasai Medical College and Research Institute, Dr. Kamachi Memorial Hospital, Madhav Medical College and Research Institute, Nagu Medical College and Hospital, Karpada Vinayaga Institute of Medical Sciences and Research Center. Your active participation, thoughtful case presentation, and commitment to pediatric academic growth have elevated the standards of this meet. We extend thanks to all IAP members who continue to be the guiding force behind academic excellence and clinical innovation in pediatrics. True leadership lies in guiding others' success. We are happy to invite our respected President, IAP Chengai, Head of Department of Pediatrics, SRM Medical College, Dr. S. Subhas, guiding and whose guidance and support. In lieu of limited time, we are also deeply honored to welcome our MS Sir, Dr. Venkatraman, who leadership and unwavering commitment to patient care and institutional development have played a crucial role in functioning and quality standards of our healthcare services. We are honored by his presence and invite him to give 2 words.
I think my voice would be audible. Respected Dr. Chengai,
நான் இந்த வேலை சின்னதா கேட்கா வால்யூம் உங்க வால்யூம் இது பண்ணி
warm welcome. I think Department of Pediatrics, they continue to organize functions. Almost every month they will have some academic program that is going on, and I think it's kudos to Dr. Subhash and designing a wonderful team as well, making it very much possible. It's always a teamwork that makes it, that makes a leader as well. That is the one that motivates the team to go further. I think it is. I think we will even go for even higher. We have a national level workshop as well. That should be our. I think we'll set that now that you have achieved all these targets. I think the target will be for you to get set higher targets for national level, probably a CME as well as a workshop to bring in faculties. So I think we are more than you have a team which is capable of achieving it, and we should be able to do it. I think my best wishes for the entire conference as well as workshop. My best wishes. Thank you very much.
Thank you, sir, for your continued support. We request all our dignitaries come forward in front of the dais for felicitation. As a token of gratitude, honor, and appreciation, we now request our respected MS Sir to felicitate Dr. Singaravelu Sir with a shawl and a memento. Now I request HOD of the Department of Pediatrics, Dr. Subhas Sir, to felicitate Dr. Venkatraman Sir with a shawl. Now we request our MS Sir to felicitate Dr. Subhas Sir, IAP President of Now we move on to a much awaited part of today's program, awards and certificate distribution ceremony. As a gesture of appreciation for the enthusiastic involvement and collaboration shown by all the participating institutes, we are pleased to announce the following recognition. Memento will be presented to each college as a token of gratitude for their active participation in this academic event. We now invite the representative of each department of pediatrics from each institute to kindly come forward to receive a memento on their behalf. We welcome our beloved Singaraveru sir to present the institutes and MS sir. Dr. Subhash sir, Head of Pediatrics, SRM Medical Hospital and Research Center. To receive a memento. Dr. Sivagama Sundari ma'am, Head of Pediatrics, Melmaruvattur, Adi Parashakti Institute of Medical Science and Research. Dr. Arivoli sir, from Chengalpet Medical College. And Dr. Dakshani madam from Chengalpet Medical College. Dr. Pragada from Kamakshi Medical Hospital. We'll be sending the mementos for the respective institutes. Chettinad Hospital and Research Center, Sri Balaji Medical College and Hospital, Satya Sai Medical College and Research Institute, Madhav Medical College and Research Institute, Tagore Medical College and Hospital, and Karpaga Vinayagam Institute of Medical Sciences and Research Center. Now this segment is dedicated to appreciate the enthusiastic participants of our postgraduate students and recognizing outstanding presentation from each institute. Dr. Divya from SRM Medical College and Research Center. Dr. Geetanjali from Melmaruthur Adi Parashakti Institute of Medical Sciences and Research. Dr. Kokila Venkatesh from Kamakshi Memorial Hospital. The remaining postgraduates, certificate will be sent to the institutes. Dr. Apranjita from Sri Balaji Medical College and Hospital. He'll also receive a memento on behalf of the institute. Congratulations to all our young achievers. Your dedication and learning and your pursuit to clinical excellence are commendable. Let's have a big round of applause for all our awardees. Other best PG presenters are Kokila Dachani from Chettinad Hospital and Research Institute, Dr. Manigandan from Sri Satya Sai Medical College and Research Institute. They will be receiving their certificates in their own institute. Dr. Kokila Dachani from Chettinad Hospital and Research Institute to come forward to collect your certificate. Dr. Manigandan from Sri Satya Sai Medical College and Research Institute. We welcome our faculty from Chettinad Hospital and Research Center to get a memento.
Thank you.
We are happy to invite our respected President, IAP Chengai and Head of the Department of Pediatrics, SRM Medical College, Dr. S. Subhash Sir, whose guidance and support have been a backbone to today's event. He adopts various roles, including being the exclusive board member of IAP Medical Education Chapter, extending his academic contribution beyond our IAP Chengalpet. We now request Sir to kindly address the gathering and welcome our guests.
Good afternoon. Sorry for the delay. I think most of the faculties and students are very eager. I will make it very short. So it gives me a great pleasure to welcome you all this month's pediatric academic meet and our 24th CPT meet, which gives a valuable platform for our postgraduate and also for the faculties to present, discuss, and refine their clinical knowledge and decision-making skills. These sessions are more than just academic exercise. They are opportunities to grow as pediatricians, to think critically, and learn from one another experience. I commend our faculties, the Chengalpet chapter, and the postgraduates for the dedication and the effort they put in to preparing their cases. I look forward to insightful discussion that not only challenge but also enlighten us all. Special thanks to our faculties and the HODs of various medical colleges. HOD of Melbourne Medical College, Dr. Saurabh Sundari, and Professor and Vice President of Chengalpet Medical College, Dr. Arivari, and the head Kamachi Memorial Hospital, Dr. Raja Lakshmi, and the faculties, and Satya Sai Medical College Professor and HOD, Dr. Suresh, and Mara Medical College HODs and other HODs, and I particularly welcome and thank Dr. Alexander HOD of Chettinad Medical College, who their valuable presence, they continuously guided, supported, and encouraged all the academic excellence. Their presence and feedback are instrumental in shaping the next generation of pediatricians. Let us make this event and most of the coming event a memorable one by engaging openly, asking questions, and learning together in the spirit of academic growth and collaborations. And I particularly take a moment to appreciate the tireless efforts of our organizing committee and academic coordinator, Dr. Balaji, convener, Dr. Harshvardhani, and the professors, Professor Dr. Sanjeev, and all the faculties of the SRM institutes. I once again welcome you all, and let's look forward to a day of encircling learning and meaningful dialogue. Thank you.
Thank you, sir. It is with profound respect and pleasure that we welcome our distinguished guest of today's event, Dr. M. Singaravelu, sir, a beacon in the field of pediatrics and a source of inspiration. Dr. Singaravelu, sir, holds a string of prestigious qualifications, MD, DCH, DNB, MNOMS, and FIAP, and currently serves as a professor of pediatrics at Vinayaka Mission Medical College, Karaikal. He has previously served as a distinction as Dean and Head of the Department at Tanjavur Medical College, and has left a lasting impact on both academic and clinical practice in Tamil Nadu. His leadership roles are extensive and influential. He is a Vice President of South Zone Indian Academy of Pediatrics 2024, Vice President East Zone IMA Tamil Nadu State 2022, Scientific Advisor IAP Tamil Nadu Presidential Action Plan 2025, Chairman of IAP Medical Education Committee Tamil Nadu 2024, District Chairman Polio Plus Rotary International District 81, President of IAP Tamil Nadu State Chapter 2013, CIAP Exclusive Board Member of 2016, 17 and 2019. Dr. Singaravelu sir's tireless service and dedication has earned him an extraordinary array of awards, including Maruthuvan Natchatra Award by the Hindu and IMA Tamil Nadu, presented by the Honorable Health Minister in 2021. Dr. Jayaraj Ayya Nadar Oration Award by IAP Tamil Nadu in 2020. Sarvapalli Dr. Radhakrishnan Lifetime Achievement for the Best Teacher by IMA TNSB. We are privileged to be in the presence of a leader whose excellent service and dedication in pediatric care, education, and community service. Please join me in extending a warm welcome to Dr. M. Singaravelu sir, a true luminary in Indian pediatrics.
I'm particularly very happy that we are having our presidential candidate for this 2025. Sir is, as you know, is a very active academician and a field level worker who's serving the IAP Indian Academy of Pediatrics for the past 40 years. So everyone know him very well. So this should be converted into vote and make Tamil Nadu proud. Thank you.
Good afternoon to all of you. At the outset, I thank Professor Subhash and his team, Ashwadini and other professors, and the unity of Chengai branch makes me really overwhelming, where we could see the leaders of professors from various institutions in and around this Chengalpattu and joining here and conducting this monthly meeting. I am proud to be here in the second annual CME. I wish that this branch should grow further and further. And as our MS was telling, surely SRM with a team of all colleges will conduct a national level conference. Already workshops are going on. Even we can plan for a national level conference when it comes to Chennai. This institute cannot be ignored. So it is a good, and Team Chengalpattu should take the lead. Always see how it is not happening anywhere in Tamil Nadu that all 7, 8 medical colleges being and DNB institutions are properly represented, and in the working day, in the lunch session, everybody is coming all the way from there. It's an honor for me to be here. I once again thank the team for giving me this opportunity. I know we are all in the lunch, usually post lunch is somewhat sleepy, but pre-lunch is somewhat very hungry, but in between. Anyway, I will not take much of time. This topic, when Subhash sir has called, sir, it should be useful for postgraduates. So what I thought this topic will be of quite useful in the era of pediatrics, where emergencies, which I am going to focus here, is it is not a big of theory, it is a case-based approach, which I am going to give some cases which we will discuss. So respiratory emergency and respiratory infection is very common in spite of lot of advancements, whatever happening in the field of vaccinology and other things, still in our OPD, if you take 70% are respiratory. And even in emergency, again respiratory emergencies are common. It is a very big topic which I am not going to take on. I am going to concentrate more of upper airway emergencies which we are coming. Why? Because it is important. See, we are in the era of rationalizing our treatment in terms of antibiotics. Because moment the child comes with a fever, with some evidence of respiratory infection, immediately there was the days we will be writing some antibiotic. Now the antibiotic resistance is the major havoc which each and every one of us are facing. And you young upcoming pediatrician should also rationalize your treatment. For rationalizing your treatment, what is more important? Your diagnosis. Unless you diagnose properly, then what is your etiology? So based on which only you can give your appropriate treatment can be done. So for which this will give you a clue. First, whenever you are sitting in OPD, a child comes to you with a respiratory problem. First thing you have to assess whether the child is comfortable or child has got able to maintain the airway. That is first and foremost important thing each one of you should able to assess. Then not immediately not make a diagnosis of pneumonia, bronchiolitis or anything. First you see, assess the triage the child, whether it can be seen as OPD or a IPD or ICU, wherever you want to treat that is. Then when a child have sudden distress, when you come with a effortless dyspnea, which is not uncommon nowadays, because the metabolic causes of where there won't be respiratory pathology at all, but child will be dying, but tachypnea will be there. But there won't be retraction. So when you're looking at the child, is the child is tachypneic or dyspneic? You should know how to differentiate dyspnea and tachypnea. Tachypnea is just increased rate. Dyspnea where the upper muscles of respiration overacting, where the child will have subcostal, intercostal, other retractions. So this is what, and you should know the difference when you see a child, whether the child is in emergency or urgency or it is not an urgent care. The difference between emergency and urgency issue. Emergency, you have to attend the child immediately, otherwise you will be losing the child. Urgency also, child will be sick, but you can have some time to evaluate the child and start the treatment. So it is not that emergency. So you should be, because when you talk about child is sick, so whether the child is so sick, so it has to be put in ICU or immediate. Whereas urgent child, you can evaluate and plan your treatment. Non-urgent case, you can do as a OPD. So coming with the case scenario, I will go quickly. So without, see, this thing is very common, especially in winter season. We come across when a 1.5-year-old child coming with cough, the barking cough. For the parents, it will be very serious problem. The child will be continuously coughing, no, and like a dog. It will be mostly in the night hours. Child won't be able to sleep, and child will have noisy breathing. So this, for the patient, they will be worried that as my child is having, they will think that the child is something is serious, is one of the very common problem. it will start with the mild upper respiratory, like running nose, low-grade fever and all that. So this is was a common and also cough. And there is a clue that other sibling also had a cough. Not this type of cough, they had some infection. When other child also having in the family some fever and infection, this child is also having, what common thinking it will come to your mind, any postgraduate? When there is one child has got one infection like fever, cough, when other siblings also have similar problem, what will think in your? Good. That's it, simple. But so this could be a viral etiology most commonly. So we not immediately jump into treating the child with antibiotic. Now we have to assess the child, then where the pathology is, how we are going to manage. This is what this case. So on examination, child is non-toxic. So child is not very sick, febrile, tachycardia, tachypnea. And of course, saturation is normal, room air, of course, 94. But you can see the stridor. Stridor, as you know, the noisy breathing is upper airway. You will be able to see. See, you can see the X-ray neck. What do you see that in the X-ray neck? The trachea where there is narrowing in the beginning, where at the upper part of the trachea there is narrowing. So where there is some edema swelling, which is this is called a steeple sign, which all over head. So what should come to your diagnosis? I think it is very clear. Croup is one of the very common problem which you come across in the rainy season and winter season. But you should think of other differential diagnosis which may have a different etiology and the presentation, like epiglottitis, bacterial tracheitis, retropharyngeal abscess as a complication, sometimes foreign, but I will discuss quickly only this time. So stridor is not an uncommon problem which we come across in our day-to-day practice. When the child comes with a stridor, you ask a history whether the child is having fever. Fever, it means the low grade fever less than 100 degree for 1 or 2 days, we don't take. Whether the child is having high grade fever or that alone should be taken as a fever. If it is a low grade fever, as this case, it may be a croup or diphtheria also will not have a high grade fever. But a high grade fever comes with the history of where this noisy breathing and all that. But sometimes the child may become very sick if you don't identify. Of course, epiglottitis, bacterial tracheitis. Epiglottitis, of course, you nowadays, you are not getting these type of cases. Where I was a postgraduate and early stage of my assistant, we have seen cases of acute epiglottitis, typical cases. We have large cases also. Because by the time they come, they will come with severe respiratory distress. Moment we intervene, child will now last. But still, he should. Why it is not uncommon nowadays? Why epiglottitis is not common? Previously, it was very common. Why it is not common? Good vaccination, because influenza vaccine, government and private sector we are giving, so the incidence. Whereas bacterial tracheitis is a newer. It is not an uncommon, which I also seen few cases. We have to think of that, and the child have high grade fever and all that. Retropharyngeal abscess also some complications of that which can discuss. And when the child comes without any preceding fever or respiratory infection, where child comes with an acute distress. Sudden acute distress, always think of any foreign body or angioedema, other rare cases. So coming to croup, as you know, it's a viral infection mostly, where child will have a barky cough and voice change will be there and stridor will be there. And because of the stridor, child may have respiratory distress, because the narrowing of the airway makes the child to take more efforts, will have subcausal and intercausal, depending on the severity of distress. The accessory muscles starting from subcausal, lower intercausal, upper intercausal, LRAC, suprasternal, everything depends on. And the stridor will be when it is very high pitched harsh shout. It means that the upper part of the trachea or larynx, below which it will be very much involved. It is not uncommon, as I said, 3%, or usual age group it is between 6 months to 3 years, and many times they don't require admission at all. For patient, they may be worried because of the cough and stridor, they'll be worried. But if you could properly identify and initiate appropriate treatment, you can treat that as OPD by assessing the child and how far it is there. So the causes is 100% viruses, mostly para-influenza type 1 and 3, and of course influenza A, B, and adeno and RSV also can cause. These are the common viral infection which will be sudden onset with the respiratory symptoms of running nose, mild cough, stridor, and this. Only what is important here is you have to assess, having assessed that is a group. I said group is a viral infection. That why I should bother? No, only thing sometimes it becomes very severe. What are the 5 parameters you have to assess when you child comes with group? Not only for group, any respiratory pathology. You have to take these 5 points into consideration. Whether child is comfortable or child is irritable or level of conscious comes down to the level of unconscious. It means the severity of hypoxemia is increasing and whether the child has got cyanosis. Stridor is always indicative of upper airway pathology from the larynx below which trachea. So any narrowing can produce as a inspiratory stridor sound. And of course, your auscultation may tell you about how far the air entry. And I told you the severity of retraction. Clinically, you can assess by looking at the child. It is only subcausal or intercausal LNSA, by which you can differentiate. So by looking these 5 parameters, you can classify it's a mild group, moderate, severe, or if I don't intervene, the child will go for respiratory failure. And that is what you clinician, when you see a child in the OPD, should be able to differentiate. Am I dealing a non-urgent case, urgent case, emergency case, very sick child? By this score, Wesley score may help you to some extent to differentiate things. So once you diagnose, it's a mild, moderate, severe, then your treatment part comes. You no role for antibiotic at all. You can give a home treatment when it is mild, whereas occasional cough, no stridor at rest, all these things you can give just outpatient where you are justified using steroid. So oral tablet of dexamethasone you can liberally use a condition called group irrespective of the severity. So this is what it is very clearly given. If it is a mild, you can treat it as OPD. If it is a moderate, how you can assess the stridor will be even at rest and frequent cough will be there and retraction will be mild to moderate. It means lower intercostal and upper intercostal. And there also you can give steroid and you can give nebulized epinephrine. That's another line of treatment. You can give epinephrine. Nebulization is one indication for group issue. Then severe cough, when stridor is severe and cough is very frequent, marked retractions, then sometimes you have to admit the child and you have to follow the child apart from giving a steroid and everything. When the child is in the state of respiratory failure, it means child is irritable or depressed, retraction severe, saturation is below A90. It means the child may go for, at that stage, you cannot be simply treating in the ICU. Sometimes you may need ventilation also, ventilator support either by intubation. This is what it is going to help you this. So this child, say when a child is having inspiratory stridor at rest, it means the score is 2 when the child has moderate subcostal retraction. So by this, what is your score which I told you? With this 4 score, is a mild or moderate? Moderate, okay, good, which you have seen that it's a moderate group. So moderate group, you can treat either as OPD or you can observe the child. Suppose you want to give oxygen. So what, see why this is important, you may not immediately examine the child in depth by putting the tongue depressor and all that. And whenever you want to give oxygen, this is a practical tip you should know. Oxygen is a drug we have to give, of course. When you are giving to a young child, you have to be, child should not be threatened. So otherwise you'll be putting the mask, child will be crying, it won't be effective at all. So better you give oxygenation when child is not very sick, you can leave the child with the mother's lap, then let the mother be comfortable, child be comfortable, then you administer oxygen. It will be very effective. Otherwise, many times in the ward you will be doing, child will be crying, our staff will be pushing the mask, child will be throwing out. That might be due to hypoxia, irritability, or general fear of it. So always it should be given in a non-threatening manner. So you immediately not give IV line and IV antibiotic, as I told you, time to preserve, and don't sedate the child just because child is irritable. You want to give oxygen, don't sedate child. We don't know whether the child is irritable because of hypoxia or just fear. Because respiratory pathology, always you have to be very careful, and immediately you not jump into making the investigation like X-ray and all that need not be done. So this is a mild group, no investigation required. Either you can give beta agonist budesonide or dexamethasone you can give. Moderate, you can give humidified oxygen support, you can give if the saturation is less, and you can give the same steroid instead of orally, you can give parenterally either IVIM. If the child is able to tolerate, you can give orally also. Only thing you have to observe for deterioration. Only in severe group where the child becomes hypoxic, severe distress, level of sensorium is altered, where the child has to be kept in ICU. Sometimes you have to ventilate and prompt sometimes tracheostomy. And this is for you to have an idea what are all the drugs and what's dosage. So only steroid which we commonly recommend is dexamethasone in the dose of 0.6 milligram per kg per dose. This you should never forget. It's a common exam questions which we ask. And depending on that, you can give orally IM, IV. If the child is responding, you can stop with a single dose. Not responding, you can repeat in 6 hours maximum, 48 hours. 4 to 5 doses you can give. Of course, you can give budesonide also, nebulization. It can be given as a 2 milligram. Again, you can within 2 days. This is one condition where you can see the mother will be very much anxious. Moment you give steroid, sometimes you give nebulization. Within 24 hours, child will become very alright. Mother will be very happy. Only thing we have to identify and appropriately treat. For this child, giving lot of cough syrups and giving antibiotic will not make any improvement at all. So you should know when to use and how to use steroid and other nebulization. Of course, nebulized adrenaline 1,000 dilution 0.5 ml per kg can be given with a normal syringe. So that this is the way you have to give. So this another case, 10-month-old child, otherwise normal child, healthy child, coming with moderately high grade fever. This history shows the child is having moderate high fever with the cough and hoarseness. So previous child have cough or hoarseness, this child also having same thing, but no drooling of saliva. The patient was diagnosed as croup because the child has got hoarseness and mild respiratory stridor was there, but the person who was seeing the child, the diagnosed as croup, so the child came to the emergency. When you see the child was having fever, high grade fever, tachycardia and normotensive, and breathing was slightly increased, not very high. SpO2 is 88 to 90, so mild hypoxia is there, and moderate respiratory distress with inspiratory stridor. So what are the differences between this case and the previous child which I told? Because so there is a stridor, there is a fever, child is in distress. So what they did, they admitted nebulization with adrenaline with steroid. They given. So child is not improving. So they repeated because within 6 hours, as the previous protocol which I showed, they tried, but child is not improving where the demand for oxygen is increasing. Unless you increase the flow of oxygen, the saturation is coming down. What is then? They did a basic investigation. What does it suggest? Total leukocyte count was increased more than 20,000. Predominantly it is neutrophil. What clue you are getting now? So high grade fever. So when the fever is beginning, when it is very high grade and it is persisting, in a viral fever also you'll have a high grade fever to start with. Then the fever will come down, will not go very high. Where you have persistence of high grade fever, when the investigation suggests you. So it is mimicking the same case where the child is having cough and stridor, but fever is persisting and child is not improving. You have to think of an infection. So then they took an X-ray, neck, as the previous case, the lateral view, where it shows the narrowing of the trachea. So, child is not improving, fever is increasing, the distance also increasing. Child is not active, comfortable as in the previous case. When it is such a situation, you have to think of something other than a simple viral bacteria. If so, what is it? Whether it is epiglottitis, or it is a tracheitis, or retropharyngeal abscess, which I told. Out of these three conditions in connection with the upper airway. Okay, it is upper airway. So child has not improved with your adrenaline, and the child has to be intubated because child was going sick. So while during intubation, they has lot of purulent secretions in the trachea. That is what a clue this condition. They when the purulent secretion they did the stain, it was positive for gram-positive cocci. And culture, of course, the rapid culture test, it is a group streptococcus. Then the child was treated with IV antibiotic with third generation cephalosporin, and of course, if it is staph, you have to give cloxylene also, and child showed improvement. What we learned from this is when the child have similar to the stridor in the season where it presents as acute, when the fever is persisting and the child is not improving, the bacterial tracheitis is another condition which we are not usually diagnosing. Now it is occurring commonly, not very commonly, but you have to, this condition is existing, which can be that the incidence, they say 0.1 per lakh children, and male predominance is slightly there. It usually follows, it is primed by a viral infection which alters our tracheal pathway, and especially if the child is immunologically unstable child. So they have easily entered, the bacteria can enter and it can cause the infection of the trachea, which can produce purulent secretion which was there. So the organisms can be staph aureus, which is very common. Then other organism may MSR, also methicillin resistant staph aureus, pneumonia, poison, monoxella, H. influenza can also cause other anaerobic organisms. These are the various etiologies which can cause, mainly by your high, you have to suspect high fever, the child will be very toxic, but other symptoms of a croup will be there, but not very severe. So this is what you can see. And typically, if you do a bronchoscopy, because now everywhere our support system has increased, a lot of our respiratory specialists are coming, our respiratory pediatricians are coming, they will be able to good in doing scopies, and they will be able to see the purulent secretion by which they can make a diagnosis. This is what you have to. So it is based on your clinical suspicion, the next day where you can see the where not only the narrowing, the altered, the lumen of this trachea is very typical of bacterial tracheitis, where apart from narrowing, you can see the tracheal lumen is ragged. The air column is not uniform. You can see the arrow. This is very classical of bacterial tracheitis by X-ray, simple X-ray. You can, if you don't have the supportive where people can do bronchoscopy, you can, and appropriate antibiotic therapy will improve. Sometimes you have to do ventilation also. This is the bacterial tracheitis. So generally third generation cephalosporin, and sometimes you have to use, it's not moving. But if it is MSRA, you have to add vancomycin. You should know when to add. You should not use all, and because child is sick, you should not use. You should go step by step. Something is staph aureus, you give amoxicillin, you can give, then clavulanic acid, then you can give cloxylene, then you can give, if it's MSRA, you can add vancomycin. And clindamycin, metronidazole, if you think of anaerobic organism also in this. So only thing, the duration of antibiotic should be for minimum 2 weeks should be given. To start with IV, if the child is better, within 48 hours, you can switch over to oral. This is what you have to do. So it may, otherwise if you don't, it's not doing problem. Okay, it may go for sudden if you don't identify properly, sudden cardiorespiratory arrest can occur, toxic syndrome can also occur. This is the complication. But if you identify early, if you treat within 2 to 3 days, child become improving, but you have to continue the duration of antibiotic for 10 days. So coming to third case, a 2-year-old child, previously healthy child. So whatever we are discussing, all previously normal children with a mild upper respiratory infection. But only this child has got fever for longer duration. Previous child, no, first case, not high fever. Second child, high fever, short duration. This child had fever for 7-day duration. So I'm not talking about, there are 7 days fever, what all you think of other tropical infection which I am not. I am talking in pertaining to respiratory symptom. This child comes with a respiratory symptom, how you are going. So it is not the discussion for a high grade fever of 7 days, how you are discussing. I am not going to that. Okay. So this child had a cough fever, then fever was lasting high grade for 7 days. Then child was having mild neck stiffness and movements were restricted. Restriction of movements were there, and child was not able to take orally because of the pain. Dysphagia was the difficulty swallowing. So if I have to discuss when there is neck stiffness with the fever, should I think of pyogenic meningitis and all that? So that all that, how in the scenario of respiratory system involvement, with this presentation, how we are going to make a diagnosis. This is what. In the last 2 days, child started crying and some muffling of sound. We won't get another. When there is muffling of sound, that is, it means that there is some narrowing in the respiratory upper airway path. If that sound has become muffled, it means that either the glottis, subglottic, or trachea, wherever it may be involved. So no history of regurgitation, drooling. Drooling will be very typical of acute epiglottis, but this child in the drooling, it means that the infection has got something. And the child had no history of trauma or foreign body, that things were not there. Child was given paracetamol and ibuprofen. Child did not improve. Child was given IV antibiotic at a local hospital because high grade fever. They tried third generation cephalosporin. Then the child has not improved in spite of high antibiotic, and the child is not showing any improvement, and having child is not able to move the neck, difficult in swallowing and muffled the sound, and child is not able to speak and difficult in swallowing. All these things have a suspicion in our mind. They took X-ray chest where they could see the expansion, the lateral neck, where there is a soft tissue swelling, you are able to see just below the pharynx. Okay, and in the prevertebral space also, which is got widened. Usually the dictum is if you take the C2 vertebra, if it is more than half size, the space is widened, then you have to think of something has got collected in the retropharyngeal phase. So for which you can do that mild right side neck swelling, and when you examine the throat, you'll be able to see the bulging of the tonsillar area where the tonsillar, because it is behind that, it's as though it is pushing forward. Here you could see the right posterior tonsillar pillar is bulging out. So they advised the ultrasound. Neck, there is a large fluid collection in the retropharyngeal phase. The bulk of collection more on the right side, and the various internal echo texture is suggestive of it is not a simple fluid collection. When echo texture is altered, you have to always think of either it could be a blood mixed with other things or purulent, you have to think. Then CT scan. CT scan always may not be able to 100% direct, but if there is enhanced in the rim of the cavity, when you say an abscess, the rim will be enhanced, so that can be seen and the septate fluid collection can be made out with a CT scan. And a CT scan can be done easily. Why the reason behind this is the retropharyngeal abscess is one condition which we have to think where child having presentation of upper respiratory infection as fever, running nose, and cough with the difficulty in swallowing and mild respiratory sound distress, and where child is not improving within a day or two, where the fever is continuously going up, even with the antibiotic, child is not improving, where child has difficulty moving the neck, and especially child is resisting movement and keep the neck stiff. And otherwise child will be conscious. Whereas in meningitis, child will be losing level of consciousness there. Here it will be caught. When you see in the throat, you can see the bulging, that also feel. These are all the clue that something more than that in the literature. We have to, by suspicion only, we can take an X-ray and of course CT and all that. Why? Because however antibiotic you are going to give, child will not improve. When there is a pus, the dictum is the pus has to be let down. So whatever may be, it is. So here in natriureteral also, if it is a pus, it has to be let down. Only thing before advocating surgery, it may be an edema, or it may be something more. So that you have to, before interfering, you have to see, because the retropharyngeal space where the lymph nodes are there, and especially young infant, young child. After 6, 7 years, 8 years, it won't, because after the lymphoid growth starts coming down. The early phase only the lymphoid growth. So easily they get infected and become, if you don't treat properly, it may get infected. So abscess formation. All this thing has to be diagnosed and it has to be appropriately treated by a help of in. That means, as we pediatrician, any child with coming with upper respiratory problem, we need not immediately send the child to ENT opinion. We can treat ourselves. Only thing we should be able to bear the anatomical lesion, then what is the type of lesion, then what is the cause for the lesion. These three things you are able to diagnose. Then when you are not able to improve with your diagnosis, you can take investigation. Then of course need the, this is called retropharyngeal abscess, which this child. So as I already explained, it can also extension. This can go for complication, or the infection can not only from throat. If the child has got other infection, can easily spread from the other, vertebral infection, osteomyelitis and all that. Or this infection can spread to the bone and spread, or it can go down, up, everywhere it can spread. It can even involve the carotid sheath, thrombosis can occur, and infection can spread other area, come down to the mediastinum, and other things also can occur. Then, or it can come from dental infection also, the retropharyngeal abscess can occur. Anyway, it can occur. And it is common, as I told you, less than 5, 6 years, and mostly winter season, males are more affected. And the reason ENT, because child will have always preceded ENT infection will be there. And the organism again, common, staphylococcus again common, group A staph, and H influenza. Organism will be all upper respiratory infection. When it goes, purulent staph is the main, of course, Klebsiella and other things may be also thought of. So this is what the classical presentation, which I already told you, that's what it is there. I'm not going to the depth. Management, if it is proved as pus, it has to be done by A&D, by orally, and the CT may not be 100%, only 63%, so that clinically you should be able to suspect and appropriately manage. And appropriate antibiotic is very important. So this is more important how to do. And the various, what are the drugs you can give, you can simply say, I don't want to go in depth of it, it will be good. So if it is a OPD, you can give amoxicillin, clavulanic acid. If the patient is allergic, you can go to clindamycin, or when you give as IV active sulbactam, or you can give clindamycin also can be given. Only in the PICU where the methicillin resistant, then you can add vancomycin, which you have to add. This is what varies. So if you don't appropriately treat, you can go for upper airway obstruction, aspiration pneumonia, extension to the mediastinum, and of course thrombosis. All these things can come. Coming to this last case scenario, this a 2-year-old boy, sudden onset of difficulty in breathing. When the child, without any preceding, any infection, fever and all that, when there is sudden onset, you will be always thinking there is no nasal congestion, rhinorrhea. But the child history is very important. Unless you carefully ask, the father says there's a choked on almond chocolate, and he is coughing after that. He'll be coughing for some time, and suddenly he will get choking and severe respiratory distress. So sudden onset of respiratory distress, always you, before going to examination, you have to be careful. You have to ask history. Typically, if there is any history of foreign body injection is there, many times you may not get also, because children, the child will be playing with the elder sibling, they will have a fear, they may not tell the truth sometimes. So we have to have a suspicion in our mind. Child will have tachypnea with suprasternal and subcostal retractions. Depending on the level of obstruction, the air entry may be good on both sides. If it is in the upper trachea till the bifurcation, if the foreign body is large, then the airway entry and auscultate both sides only. Unless it goes to the right main bronchus where it gets obstructs on one side, the air entry may not be severe. But whatever it is, if there is support oxygen, and radiography should be taken as early as possible. So, and this by, if you have a suspicion that history, if you believe that the child is having, then it has to be taken out by foreign I mean, because many times the X-ray may not give you all the, because radio loosen and even suppose foreign body, you may not be able to see in X-ray, but still it is X-ray is important. I'll come to that later. As you know, choking is very common in a young child, especially less than 2 years, 3 years, and it's very common. And because many times children will be playing and they'll be, while they are eating, they'll be laughing, they'll be shouting, suddenly they'll get aspirin. And they, of inquisitiveness of putting everything into mouth, they will keep everything into mouth, suddenly they get aspirated. So this is especially one of the problem. These are all the various things can get as a foreign body, nuts, seeds, and candy, gums, magnets. So it can either go to GI tract or respiratory tract. We are talking about respiratory tract, we have to be very careful, because even GI tract, if it is a button battery, it is an emergency. Other things we can wait and will not be very sick. But whatever may enter into the respiratory tract, it is a serious and you have to immediately. So, because as a child airway is easily get obstructed because of the narrowness, the diameter is less thickened. And once the foreign body enters, the secretions also will be as a reaction, it will happen. That way again narrow the airway, then they go for obstructions. And the child will, a young child may not be able to forcibly bring out. If the child has got able to do Valsalomani, if it is able to forcibly expel, cough, it may come out. But in a young child, it's very difficult. So you should be very careful there. It may present from asymptomatic to complication. Initially, even what will happen, the moment the foreign body enters, child will have paroxysm of cough, choking, and all that. After that, it may get lodged somewhere. Child may be comfortable for some time, depending on the, if it is a mild obstruction, no, child may not have symptoms. And child may not be able to expel the foreign body. What will happen later on after the asymptomatic interval? It becomes lodged. Child may not be able to bring out. And later on, it may go for complication like erosions, that leads to obstruction, infection, and all that. Then child may later on manifest other symptoms that you have to keep. So history is very important. Positive history should never be ignored. And a comprehensive physical examination, choking or coughing, whenever there is, yes, child has come with a new wheezing, and when it is asymmetric, when the right side you get something, left side not getting, then you have to always suspect a foreign body. So radiology, as I told you, in many of them was already opaque, where you may not be able to in the plain film, but you can get the secondary findings like air trapping. Suppose it obstructs, so air trapping can be get. Partial obstruction can produce obstructive emphysema, hyperinflation, or it can cause collapse also. If it goes into the terminal blockers, you can see the collapse. And depending on that shift, you can see. If it is hyperaerated one side, the mediastem can shift. All these things, consolidation due to secondary infection, all these things, secondary findings you can get by taking a simple X-ray test. So these are all the various foreign body. You can see laryngeal foreign body, groundnut in the right main bronchus, producing obstructive emphysema where there is emphysema stages of the whole right lung, because it is a right main bronchus, the whole lung. The mediastinum also slightly start shifting. See, this is very important for you. See, the coin is one of the very common foreign body. It may be for button battery also, both is because both are mimicking. If it is a button battery, whether it is respiratory or GIT foreign, you have to act immediately because it is very serious. It can go for erosion, necrosis, all come. If it is a coin, if it is esophageal, you need not be very emergency. If it is respiratory, then so how will you know that whether it is a respiratory or esophageal? Because you are all very hungry. I am not asking more interactively. I am not going because I want to finish quickly. Because if it is a esophageal foreign body, this is very important when you take an X-ray AP view. If you could see the full round coin, it means in the AP view, it is in the esophageal. In the same AP view, you see the lateral part of it. What you see in the right side film, you can see the lateral part. It is in the tracheum. This two film in the AP, you can now assess, is it an emergency or urgent? So this is an, which is the airway is an emergency. It is an urgent. I told you what is an urgent and emergency. You should know the difference. So this you have to act quickly and you have to take appropriate help of a person who are involved. So in the lateral view shows the edge in the esophageal foreign body, where here in the lateral view, full round coin will be seen in the respiratory, if it is in the respiratory tract. This is what most important point which. So once you diagnose, prompt endoscopic removal is the line of medicine. Unless you remove that foreign body, it will end up in. So this is what, and of course, this is how airway, you all attended BLS, ALS course. I am not going to how you have to approach. So this picture tells you the differentiation, what I discussed, acute epiglottitis, which is not nowadays very common, as I told you, but it child will be very sick and drooling of saliva will be present, sounds will be muffled. It is a very quick answer. Yesterday, child will have a low-grade fever, mild cough, running nose. That day, night child become very sick, and the child will keep the neck in extended push, and it will be typically will be keeping the leg like a finger, hand in a particular position because it will not be able to flexible to keep like this. That is when you see that very typical in X-ray, you will be able to see croup. I had discussed bacterial tracheitis and retropharyngeal abscess. How all these things you should be able to differentiate all these things. Same thing, if there is tracheal tenderness, when you just touch the trachea, when you suspect bacterial tracheitis, will be positive. In other condition, it will not be positive. The proper positioning, as I told you, acute epiglottitis, the tripod position with extended neck, or the child in tracheitis, the retropharyngeal abscess, they will always keep the neck stiff, and torticollis may be there. So these things will give you a clue where are the infection and how we have to approach. So with this, these are all the algorithm which I already explained. When a child comes with some signs of respiratory infection with obstruction, whether the child is having severe obstruction, then when the obstruction is severe, don't bother about etiology. You have to save the child. First, you have to maintain the airway first, either by intubation or tracheostomy. After that, you can, otherwise, you will be going on thinking so many conditions and missing the child intervention, you will be losing the child. When the child is not having severe obstruction, then it is not an emergency, it is urgent. So if it is a fever, then you think of high grade fever. No fever, say foreign body and all that. This is how what I already told you. If the child has got low grade fever and all that, and with high grade fever, if the neck pain stiffness is there, as I told you, it can be retropharyngeal abscess, or sometimes if typical position is the epiglottitis. And barking cough with tracheal tenderness, bacterial tracheitis, peritonsil abscess also. So these are all the way you have to approach a child. So the ultimate the point of discussion is whenever child, though present as an emergency, when you think that is a desperate emergency, you have to identify what could be the site of whether it is above supraglottic, infraglottic, suprathoracic. All these things first you have to identify, and whether the child is very sick or not, whether you need any supportive system and all that. Then third come to EGR, whether it is a. So don't jump in starting antibiotic, because we are in the era of antimicrobial resistance where everyone has to keep in mind before writing any antibiotic. Am I justified in prescribing this? Youngsters, you should be mainly for that. This is so. Even however the child is sick, it is not that antibiotic is the line of treatment in a sick child. So only thing, depending on the cause, which I told, when the fever persists, when there is clinical evidence of acute bacterial infection, then you are justified in starting appropriate antibiotic. Otherwise, you can. This is the main purpose of taking this topic. And once again, I thank Dr. Subhash and the team of entire Chengai team, with surrounded by 7-8 medical colleges, and give me this opportunity to be with you all in this very good gathering. And once again, thank you.
Thank you, sir, for gracing us with your presence today. Your journey continues to inspire generation of pediatrics across the country. On behalf of the Department of Pediatrics from Satya Sai Medical College and Research Institute, we request their postgraduate to receive the memento for active participation in Chengai meet from Dr. Singaravelu, sir. Now, I request Dr. Balaji, sir, Professor, Department of Pediatrics, to deliver the vote of thanks.
Good afternoon all. So Chengai Pediatric Meet, it started as an idea. So we have City Pediatric Meet in Chennai. It was very difficult to reach there. So why not we have a meet for ourselves? It was just an idea, and from that 2 years on, every monthly we have been doing continuously this meet. And I think the first person to thank is our IAP President, Dr. Subhash sir. So from idea, we converted it into reality. So every meet, he shows the same energy. Thank you, sir. Next is all the medical colleges. So together, so all the head of departments, Dr. Sivagam Sundari ma'am, and Dr. Suresh sir, Dr. Jayashree ma'am, I think ma'am is in online. Dr. Rajeshwari ma'am, and from Balaji Medical, Dr. Sundari ma'am, Dr. Ravi Kumar sir. They have been all the pillars supporting this initiative. Otherwise, it would not be possible. And I think from this year, Tagore Medical College and Mother Medical College will also be actively participating. And I wish to all the faculties who have participated, supported. Special mention to Dr. Alexander sir, Dr. Kritika ma'am, Dr. Ramya ma'am, Dr. Rahul sir, Dr. Ashok sir, Dr. Prasanna sir from our college. I wish to thank all the postgraduates who have actively participated, presenting cases. It was a learning curve for all of us. And the whole IAP team, Dr. Arivali sir, Dr. Saujan, Dr. Suresh, for supporting this event. And from the backside coordinating, Dr. Harshavardhani, Dr. Sahul, all the technical support, Dr. Tyagarajan. So, and sponsors, not to mention the sponsors, Torrent and Apex Pharma, they have all made it a success for monthly for all these 2 years. And for today's event, Dr. Chengai, sir, thank you, sir. So our VP and I think future president, I would say, all the best, sir, for your future endeavors. It was a wonderful talk. And today we were blessed with our medical superintendent, I thank, and SRM management for supporting. Thanks to all the faculties who have come all the way here, Dr. Prada ma'am, Dr. Dakshani ma'am, Durgam Sundari ma'am, Dr. Arivali sir, Dr. Rahul sir, Dr. Kamlesh. Thank you. And our unit chiefs, Dr. Prasanna sir, Dr. Sanjeev sir, Dr. Ashok sir, and sponsors for meet and lunch, Torrent and Apex, and all faculties and postgraduates. Thank you very much. We'll keep continuing. And pediatric surgery, HOD sir. Thank you.
So I should thank all those who have joined in hybrid board. I didn't mention that. Thank all those who are in Zoom meet. Thank you for giving this opportunity, and it's a wonderful idea that you are creating every month, so it will be very beneficial. Actually, 2-3 months back, when I saw that, I immediately joined, and immediately Subhash had called me to talk me. So it was a good one, a good lecture, sir. Thank you.
Thank you. So we'll discuss for lunch. Thank you.